Hello, and welcome back to the Acro Educational video series on radiation oncology basics. Today, we're going to look at the imaging techniques that are most commonly used to make sure a patient is in the right place before treatment begins. These techniques form the basis of image-guided radiotherapy, also called IGRT. So what techniques do we use for IGRT? Today, we'll review three of the most common. These consist of MV or portal images, KV images, and cone beam CTs. The MV and KV refer to the energy level of the photons used to generate the images. As you can see, MV images use higher energy gamma rays to generate an image of the patient. This is the same type of radiation delivered during treatment, and it's delivered by the treatment machine using the same equipment it uses to deliver an actual treatment. As such, the picture that results is a beam's eye view of the treatment field, which is why these are also called portal images. KV stands for kilovoltage energy, which is a lower energy more typically used for diagnostic imaging, such as regular X-rays and CT scans. On the right, you can see an example of an MV image for a breast cancer treatment. The film is generated by placing a detector directly across from the head of the gantry, as you can see here on the left. The result is a picture of the beam's eye view, including any adjustments to the beam shape, such as the use of multi-leaf collimators, which we can see in this case to block the lung from the treatment field. However, there is a reason that most diagnostic imaging is not performed with MV photons. The image quality is considerably poorer when compared to KV imaging. Since KV imaging uses KV energy, we can't take an image from the beam's eye view using the gantry. A separate system has to be installed to both generate the KV X-rays and detect them after they've gone through the patient. As you can see on the left, these systems are typically installed at a 90-degree angle from the treatment beam. As such, the KV images generated are often called orthogonal images. On the right, you can see that these images are often superimposed on an image called the DRR, which is generated from the patient's CT simulation. This allows the correct setup to be verified. Depending on the treatment system, the DRR and the KV image may also be placed side by side, as seen here. If differences in positioning are noted, the isocenter can be shifted appropriately to ensure the patient is aligned correctly. Here's a summary showing how MV and KV images are acquired. In this case, the patient has implanted fiducial markers to mark the location of the tumor, which you can then see on the images. The main limitation of KV imaging is that it can only really be used to visualize bony anatomy, much like a regular diagnostic X-ray. For some disease sites, such as prostate cancer, it is very important to be able to visualize the soft tissue itself. This allows tracking of anatomical changes, such as rectal filling and bladder filling, which are invisible on KV images. Just like a regular CT scan, a cone beam CT is constructed by taking many different images and reconstructing them in 3D. This can theoretically be done with either the KV or the MV imagers, though the KV is used more commonly. As you can imagine, acquiring a cone beam CT requires much more time than a KV or MV image and also leads to additional radiation exposure, so it is primarily used only when that soft tissue visualization is important. That's it for our introduction to film checks. Thanks for watching, and don't forget to join ACRO and visit our website for many more great educational resources.